What do you do when a patient presents like this? That's what we're going to talk about today. So I'm Dr. Michael Miyazaki, and it's really fun to be able to show you cases like this. So let me show you what we did. As this patient comes in, and you can see that on lower anterior area, she's got a lot of bone loss. And her concern is that we can take these teeth and obviously wiggle them back and forth. There's a slight space between 26 and 27, the lower right lateral and cuspid, and she was asking for options because it was starting to hurt when she was eating and these teeth were being wiggled. So what we did is we offered her the rib-on splinting, which we talked about in a previous episode. So that's what I want to talk about today is using rib-on, which is a bondable reinforcement ribbon, and its versatility, especially in cases like this, because think about what the options would be. So here's the rib-on kit, the box that's kind of been the same box that we've seen for the last few decades. And so it's a very familiar box that's in our office. What makes rib-on so good, again, we talked about this before, it's a flexible, ultra-high molecular weight polyethylene fiber or fibers with very little memory, so it's very easy to place. It's biocompatible, and because it adapts so well to the teeth that we're bonding it to, we get what they call the laminate effect, which means there's very little cement between the tooth and the fibers, which makes it stronger. It's very aesthetic. One of the concerns that this patient had, and the nice thing about it is when you buy that box, it has an indefinite shelf life and you don't have to refrigerate it. So let's go back to the case. Patient shows up. She's in her 80s, but she's cognitively very sharp. But down here you can see there's a lot of hygiene issues. We've got bone loss, and she has some other implants on her lower right hand side. But these lower anteriors, we've got bone loss, just continues to progress, and you can see how bad the tissues look down there. She comes in because her main concern isn't the inflamed tissue, but it's that when she's eating now that the teeth are moving and it's very uncomfortable when they move. So she asked, what options did she have? Obviously, well, we could take out the really weak teeth. That is an option. So here you can see that there's a lot of bone loss down there, right? So if I was to pull those teeth out, okay, that's an option. But if we pulled those teeth out, we might have to go to a partial denture, or if you just deemed all the teeth on her lower arch to be in the teeth and maybe do some kind of fixed bridge work down there. So all options. But the option that I felt was the easiest was just to splint the teeth together. I explained to her that if we splinted the teeth together, it would take these teeth that were kind of loose, and by splinting them, it would make them strong again. We've done this for decades on other patients that had as much bone loss as her, or sometimes even more. What's the great thing about splinting? The speed. One appointment, we can get this done. The cost, well, the cost is going to be much less because we don't have any lab work. It's one quick appointment in the office. And the effectiveness of the splinting is her teeth are going to stop moving. And the biggest complaint she has is the discomfort. Now, what she asked me was, when you do this, are people going to see it? Like, is it going to be noticeable? And I told her, no, this fiber is tooth colored and the materials that we use are going to be tooth colored. So it's going to be very aesthetic. Another question was, will she be able to clean around this area? And I said, yes, she'll still be able to clean because we're going to keep that fiber, the connector, way away from the tissue so she won't be able to floss as easily. She could thread floss through, but she still could access the gum and the bone areas. And so periodontally, we weren't going to compromise her any further. So what Ribbon does is Ribbon comes in a nice little kit, that box I showed you. It's got lots of instructions for all the different indicated uses you can use Ribbon for. It has wetting resins. It has securing flowable composite. It has the scissors to use when you cut it. And there's different types of fibers, but the kit that I have is the Ultra Ribbon Ultra kit, and we have a 2 millimeter, 3 millimeter, and 4 millimeter wide fibers that we can choose from. So how do we start this case? Well, those lower anterior teeth were already wiggly. So I told her one of the things we're going to do first is I'm going to just kind of spot them together using flowable composite just so they're not moving, because you can imagine trying to place a fiber, and these lower anteriors were tipped lingually, and trying to get a fiber on the lingual side was made even more difficult because of that. So I told her I was going to take the teeth and just kind of secure them with some tooth colored filling material. So what we did is I went in here with a fine diamond and just kind of roughened up the enamel surface a little bit, just so we would remove any plaque, calculus, and roughen the enamel surface up. Then I went back through those areas and we used air particle abrasion, again, just to roughen the surface up and kind of break the glaze, so to speak, of the teeth so we would get better etching. On the implant, on that lower first right bicuspid, that was an implant crown there, and the crown was zirconia. So what I did is I cut that little shoulder in there on the mesial lingual of that because I just wanted to tie the fibers into something on the lower right hand side that wasn't mobile. So then you can see the white powder, that's from our particle abrasion, but I took our velvet etchant that this apex 40% phosphoric acid stays where you put it, and I put that into the interproximal areas between the teeth. And what we're going to do is we're going to rinse this off, place a bonding resin, then flowable composite between the teeth, and on that lower right-hand side where the lateral and the cuspid were, and there was a diastema there because the teeth had separated, I pushed the teeth to close that space up, and then we bonded it all together with flowable composite. So now at least the teeth aren't moving. And now we're going to focus on getting the fiber in on the lingual side because that's truly where the strength of this splinting is going to come. So I took my probe and I just kind of spot measured the teeth across that area. We were going to do from lower left canine over to lower right first bicuspid. And so I measured that out. Then we went and placed that foil that I showed you before. We cut the foil to that length. I placed that foil on the linguals of those teeth. We were good measurement wise. So then I take that foil to the ribbon, and when the ribbon is clean like this, you don't want to touch it with your gloves or your fingers because that'll contaminate it. So when you're manipulating this fiber at this point, we're using cotton pliers. So I cut it to length, and then what we want to do is we want to put an on-filled resin onto that ribbon fiber, so to wet it. And in the kit, it actually has this little yellow hand that says, "Do not touch the fibers until you put an on-filled resin on it." So we got the on-filled resin into our fiber, and you can see now it's set to go. Now, if I wanted to touch it, I could, but I still try not to. I still just use cotton pliers or other instruments. Then we place our velvet etch on the lingual side. Now, this is the area that I had done the air particle abrasion with. So the tooth was ready to be etched. I placed this 40% phosphoric acid on the lingual where the fiber was going to go. We rinsed that off. It had a nice frosty etch pattern. And again, this was difficult. So we only etched the areas we needed to etch. We didn't etch like the root surfaces because that would just make this a mess, right? So I love the velvet etch because it stays where we put composite so that when you place the ribbon fiber, the fibers go into that composite and don't pull away. It kind of, it's like honey consistency. It kind of sinks into that securing composite. So what I did is once I got that securing composite in place, I cured my ribbon into that, but I didn't mess around with that zirconia crown yet. On the zirconia crown, you can see my ribbon fiber is fitting into that little shelf I created, so everything fit perfectly. And what I did there is I used ZRC because the saliva had contaminated, fixated against that restoration. And then I placed an adhesive between both. I just used the Regen universal adhesive, and then I light cured that and placed composite over the top of that. Again, a flowable composite, and cured that. So it was very easy to do. When we got done, the patient was amazed because remember, she was concerned about the aesthetics. Well, here's a close up. Aesthetically, doesn't look too bad. I mean, compared to what the teeth around this splint look like, the splint actually looks pretty good. It's very cleansable. The other patient concern the patient had was could she clean? And now you can see she can clean in between those teeth very well, right? She could take a little interdental cleaner and clean those areas or a water pick, and she can still access those areas. But what she loved was she could put her finger there and bite down on those teeth, and they no longer moved. And because they no longer moved, she no longer had the discomfort. So everything was kind of accomplished. Aesthetics, cleansability, and comfort was reestablished. And you can see on the left-hand side of our screen where that lower right first bicuspid was, and I had cut that little shelf in the zirconia, how once we blended that in with the flowable composite, you can't even see it, right? And that just gave this whole splinting just so much stability. It was super strong. On the lingual side, you can barely see the fiber. It's well covered with the flowable composite. There's no exposed fibers. And when she ran her tongue back there, everything was smooth. She had no complaints with the lingual side. So the results were happy patient. Patient loved that the teeth were no longer mobile. They felt strong and secure, and that meant the discomfort was gone. And she loved that it was smooth on the back of her teeth now. She loved the appearance because she couldn't see anything. It was practically invisible and very cleansable. So I will tell you, if you ever have a case like this, there's a lot of different options, and a lot of them are going to be very costly to the patient. And when you have teeth that are compromised, you're trying to figure out, should I do that or not? And I will tell you with this, we don't have a whole lot to lose. It doesn't cost the patient a whole lot. It didn't take much time to do, but the patient's just really happy. And I've been doing this for decades. And we've had some great results with patients where their teeth were just wiggling in the wind. You know, every time they swallowed, the teeth were moving. Every time they bit down, the teeth were moving. And we secured it, and they were happy. And it's been decades that these fibers have been down in those mouths. And I just wanted to share this idea for you because most likely someday you're going to have a patient that could benefit from this. So anyway, I hope you like this, and I will see you during our next episode. Take care.